Hi, good afternoon. This is the next segment of the Good Samaritan University virtual classes, and today's topic is going to be about breast cancer, and in particular, what it is at Good Samaritan that we have to offer and that we think we do so well. The main focus of the talk today is going to be about our high-risk patients and their risk of getting breast cancer and what we do in terms of screening them and treating them, because high-risk patients are somewhat different than the rest of our community. So everybody is at risk of getting breast cancer, every woman and some men, and we screen people very carefully, and we know that if we catch breast cancer early, we can cure the vast majority of patients, and if we catch it late, we're not so good. And so it's really important to do our best to screen people and to try to catch these cancers at an early stage where it's very curable and very treatable. And this is fine for the average person, and we have very good protocols for this. But what we've done here at Good Samaritan and some other places in the country is established a high-risk screening program. And what this is enhanced surveillance for people at higher risk. And the average screening protocols are not good enough for people at high risk. And so we need to identify who these people are who have an unusually high risk of getting breast cancer and screen them better than we screen everybody else. Breast cancer is really common. I'm going to move through some of this pretty quickly, but 1 out of 8 women in the United States develop breast cancer at some point in their life. And that, of course, is a huge number. It's common enough that everybody knows people that have had breast cancer because it's just that common. And fortunately, part of the reason that you know people that have had breast cancer is because they've done well. They're alive and they're okay. So early diagnosis, I mentioned. Screening programs, we use mammography. That's really the mainstay of our screening. But there are other modalities we use also, in addition to self-exams, doctor examinations. Sometimes we use other radiologic studies. And again, this is why it's so important. Stage 0, you can see at the top of your screen, an excellent prognosis, whereas stage 4, you can see that people do not live very long. Hugely different, very, very important. When this is just sort of a schematic, but the idea is that you find a cancer when it's very tiny at the bottom of your screen if you get regular mammograms, and at the top of your screen if you're not having mammograms and routine checkups, the tumor is going to be much larger by the time it's diagnosed and found. So risk factors, what makes somebody high risk? And so part of it's their own personal history, and also their family history, whether they have a genetic predisposition of some sort, their heritage. Ashkenazi Jewish people in particular may have a high risk, whether they've been exposed to high doses of radiation in the past, such as some lymphoma patients. And then other issues that are somewhat less important, but also still important in terms of pregnancies, age of menopause and menarche, hormonal supplementations that are used, activity, weight. And these are things that we all put together to try to identify who our high-risk patients are. And a lot of women will say when they get breast cancer, why? How come I got breast cancer? And most of the time the truth still is we don't know. But we're starting to know better and better. And part of the way we are knowing better is by screening people better, doing genetic testing, meaning looking for something like a BRCA gene, the BRCA genes that most of you have probably heard of. And this is part of our process that we're using to try to identify why people are getting breast cancers, and the next step being how to prevent that. So what is routine screening? For the average person, you will see that different organizations have somewhat differing recommendations. This is a good and average one, starting at age 40, yearly mammograms, clinical breast examinations by your gynecologist or primary care doctor, and being self-aware, checking your own breasts from time to time. Sonography is sometimes used as an adjunct to mammography. Mammograms are very good. If you add sonograms to mammograms, sometimes you can improve your rate of catching an early cancer. Particularly good in young people, people with dense breast tissue, or people at higher risk. We're also now using MRIs a lot to screen the breast, but this is really just for unusual circumstances or for people at high risk. So if we can define somebody's risk of getting breast cancer in their lifetime as in the 20 to 25 or higher range, then MRIs are generally recommended. And MRI is another type of X-ray test and extremely, extremely sensitive, meaning that it does not miss very much at all. And we find breast cancers occasionally on MRI that would have taken another year or two, or who knows how long, to find by our standard modalities. And this is part of our enhanced surveillance high-risk program. This slide doesn't show very well, but this is an MRI, and there are two breasts in that picture, if you can tell, and the one on your right, I guess, has a big white spot in the middle. So just an example of just how obvious cancer might be on an MRI study, and sometimes it's not obvious at all on some of the other tests. So in addition to finding cancer, there's some other things that we find when we do screening and do biopsies of suspicious areas, and this is a list of them. I'm not going to go through them all, but these are high-risk lesions, and these tell us two things. They tell us, one, that we need to do a very careful biopsy of this region to make sure that we're not missing an associated cancer there, but it also tells us that this particular patient may be at significantly higher risk at some point in the future of getting a more serious breast cancer process. So high-risk screening. So if you're identified as being a particularly high-risk person, what do you do that's different than the person who's average risk? And this is my list, but pretty well accepted. And so I think that the average person should have a physician breast examination once a year. And so I recommend that particularly high-risk patients should have a doctor examination twice a year. For my patients, what I often tell them is to come to me once a year, go to their gynecologist once a year, separate us by 6 months, and therefore every 6 months you'll be being checked by somebody. Continue checking yourself, have your annual mammographies, and consider adding sonography, especially if there's dense breast tissue. Undergo genetic counseling and testing. And so this is a blood test or a sputum test, and this will tell you whether there's a familial gene that you have inherited that puts you at high risk, such as the BRCA genes. But now we have a wide panel of genes that we look for, much more than just these BRCA genes. And they can be very helpful in terms of identifying who's at high risk, identifying how high your risk is, and also helping to identify whether you're at risk of other important cancers. And some people, unfortunately, are. Your family history is key, and we always focus on people. If you have your mother, your sister, your aunts, other people in your family have had breast cancer problems, you are at higher risk, and just gives us an extra clue that we should do genetic testing, that we should look very carefully and watch. And then the MRI screening, as I mentioned, for those at high risk, very useful, very important. And these are things that we are now doing pretty routinely here at Good Samaritan. I think we were by far the first hospital center in the area to initiate a high-risk screening program, and it's going forward quite well. It's been very productive, and it really keeps us on top of the screening of our patients and being able to provide a better screening and a better patient care overall process than what you might see really pretty much anywhere else. So the high-risk screening we mentioned a minute ago. So risk reduction. So if you're at high risk, what do you do? And so we talked about high-risk screening, or what we call enhanced screening, but there's another half of this. And so catching the breast cancer early, treating it effectively when you catch it early is great. But wouldn't it be even better if you could actually prevent the breast cancer in the first place? And harder to do, but there are things that can be addressed. There are lifestyle issues, and these are things like avoiding being overweight, making sure that you exercise, not eating too much in terms of fatty foods, not drinking too much alcohol, and these things help to certain degrees. If you have a genetic predisposition, you inherited something from your family, obviously you can't change that. But there are other modalities that have been used very effectively. For people at high risk, there's actually what we call chemoprophylaxis, or hormonal prophylaxis. And what this is taking an estrogen-blocking medication. And it has been shown pretty definitively that for people at high risk, if they take a hormonal blocking or an estrogen blocking medication, that they can reduce their risk by about 50%, so pretty significant. There are potential side effects. It's not for everyone. It's something that has to be carefully discussed with you and your physicians, but a very useful, potentially, modality to decrease your personal risk of breast cancer. For people at extremely high risk, we can do surgical prophylactic procedures, and this is removing the breast. Really extreme, certainly not for everybody, but for those people that have had very strong family histories, people that have tested positive for things like the BRCA genes, and some of these people, their risk of getting breast cancer might be as high as 80 or higher % in their lifetime. And if your risk of getting cancer is that high, some people choose, not everybody, some people choose to have their breast removed before they get their cancer rather than waiting and then having to go through the surgery. And part of the reason is that if you had the cancer first, you might need radiation therapy, you might need chemotherapy, you might need a lot of things that wouldn't have been necessary if you were able to prevent the cancer in the first place. So again, something that needs to be discussed between you and your doctors. Not for everybody, but sometimes a very useful and important modality for us. A few other things I just wanted to mention in terms of what we're doing here at Good Samaritan. And so this high-risk screening program is really just one of a number of things that we've been doing here. And we've been doing this for many, many years. We've had the first real breast cancer program anywhere in the area. And we have what's called a multidisciplinary conference. And a lot of hospital centers have now started doing this, but even though they are catching up, they're still not doing what we're doing. And every single Friday morning, we have a meeting. We get people up at 7 a.m. to attend this meeting every Friday morning. And we have surgeons and radiologists and nurses and pathologists and oncologists and an endless list of people. And we sit together and we present cases and we review how to take care of all these patients together, and it's extremely educational for all of us and extremely important for the patients. We often do it in what we call a prospective fashion, meaning that we present the case as it's ongoing and we haven't made all the final decisions yet. We haven't provided all the care yet, so we have an opportunity for this collection of people to give input and make sure that everyone agrees that we're doing the best possible thing for each of these patients. And this is ongoing, and we've managed to do this right through the recent COVID process, which I think has been a kind of a remarkable thing. So much cancer care all over the country has really been affected by this COVID crisis. And somehow we've managed here not to let that happen to us. We've been taking care of our cancer patients the whole time through. I read things online all the time about what should you do for your cancer patient when you can't give them the proper standard care. And at first, when I read them, it confused me a little bit because we were able to give them the proper standard care the whole way through. And all these articles were describing, well, what's the second best treatment that you can give them? And we never did that here. We gave the first best treatment the whole way through. We're still doing it now. And if there are more COVID problems around the corner, we're going to keep doing it. Other things that we're recently adding to our program, we've recently advanced to what we call synoptic reports, new ways of documenting our care, which is really important in terms of data collection and in terms of making sure that everyone is doing the right thing for all of our patients. Thank you. For more information, I have something written down here I will read to you. Please visit www.good-samaritan-hospital.org. And online, you'll have access to this lecture and to other information and a number of other lectures that Good Samaritan is also providing to you. Thank you.